Hi, my name is Dr. Ross Hauser. Welcome to the Hauser Neck Center in Caring Medical, Florida, here in beautiful Fort Myers, Florida. I'm here with my associate, Danielle Matias. So Danielle, a lot of the folks wouldn't realize one of the reasons why you actually haven't been on these YouTube videos is that, you had something significant happen in your life. And what was that?
Back in March, my husband and I, we had twins born at 25 weeks. So that was very unexpected and very scary. So we took several months off to spend time with them. They were in the hospital for about almost 4 months until they could come home. So we were there every day. Now they're home. They're doing amazing. They're doing great. So
awesome.
So now I am able to come back to work.
No, and then, I think they told you that the more time you spent at the hospital, their survival was greater. So
they did.
And then I'm proud of the way the staff rallied around. We just ran the practice. We basically ran your practice too during the time. And then obviously when you first got back, you just need to get back into the mode of things. So appreciate you spending some time to do some videos. And one of the things that we see quite commonly is headaches. And we're going to do a 5-part series, so it's going to be, quite a bit of information. But it's always intriguing to me that modern medicine, they usually don't get at the root cause of headaches, right? Because often the treatment is just various medications.
I would agree. People don't have chronic headaches because their body has a deficiency in Tylenol or Advil. That's not why you get a chronic headache. And really, what's considered normal is 2 headaches a year. So that is actually considered a normal thing.
Yeah, that's probably what I get.
Yeah, but I'm assuming that many of you watching get much more than that. Headaches every day, multiple days a week. And so that kind of more chronic category is not, the patient that should be taking, in my opinion, ibuprofen and Tylenol every single day for headaches. We have to find the cause.
Medicines treat the chemical part of the disease. It doesn't treat the structural part. And you had mentioned even before we started this video, you had said, again, we're probably going to cover the forward head face down lifestyle. So clearly, I would bet if we looked at the incidence of headaches, I'll bet you the incidence is probably increasing since we got computers and since we
got
cell phones. And then you and I believe the number one cause of headaches is basically ligament problems. So we're just going to dive right into ligaments. So the ligament etiology of headaches. I so much like this figure because it shows how cervical instability can lead to various kinds of headaches, and it's basically all the kinds of headaches. You could categorize structural headaches into 1 of 2 categories. The one category is C0, C1, C1, C2, or upper cervical instability. So here, I'll just grab this. So upper cervical, this is a beautiful model. So this is basically what the neck vertebrae look like. So the top vertebrae is the atlas. And then when you do the forward head face down lifestyle, you could see that the atlas goes forward. The atlas is going to go forward. When the atlas goes forward, it blocks CSF. So basically this side of it is really mostly upper cervical instability, because upper cervical instability can put tension on the brainstem, and that's where the nausea center is. And then this side of it, especially this part over here, is often lower cervical instability. And then the muscles are recruited to stabilize the vertebrae when the ligaments can't. So that's where you get like tension type headaches. And we all know, most of us have had anyway, where we went to a chiropractor and they've done some type of adjusting, and then our headaches or neck pain has gone away. So somebody whose vertebrae continued to slip out of place, you have to think of, probably the cause of it is cervical instability, and really the way to resolve it is going to be prolotherapy. Then here are some signs and symptoms of cervical origin of headaches. So what are some common ones?
Common things that patients will say to me, because there are headaches, of course, that don't have a neck component, but if you can tie your headaches to how you move your neck or certain positions, or people, I've heard, anytime I realize I'm sleeping with my neck rotated, I'll get a headache. These are clues that there is a neck component. Even like what you have listed here, if you are somebody that you have limited range of motion, you can't move your neck a lot because of muscle tightness, that can definitely be related to a headache.
If somebody has clicking, popping, grinding in the neck, like that's not normal.
Right.
And then often in the patient population we see, if you have other signs or symptoms of cervical instability, such as dizziness, vertigo, ringing in the ear, swallowing difficulties, heart palpitation, POTS, other symptoms, then it's likely that you have a headache of cervical origin. And then of course, people will often say, I'm just telling you, it's like always tight here, like it's always tight here. So if it's really high up, you probably have upper cervical instability. And then if it's down here, you probably have lower cervical instability.
And you kind of touched on this before, but patients, again, things that I've heard, they have a headache, they go to the chiropractor, they get adjusted, maybe there's a big pop during that and they feel better instantly, but these headaches keep returning and they keep having to go back to the chiropractor. And patients will often say, my adjustments aren't holding. Doesn't mean it wasn't adjusted well, it's just you don't have the ligament strength to hold it there. So as your vertebrae keep twisting and rotating out of place, you're gonna keep getting headaches until that's resolved.
Yeah, that makes a lot of sense. And then these are basically some of the ligaments that we treat. And of course, I've mentioned this before, but you wrote a really nice paper on the capsular ligaments. So anybody who wants to read about cervical instability and specifically how capsular ligament injury can cause all kinds of things, including headaches, recommend that they read that paper.
Yeah.
So talk about the capsular ligaments and why are they so significant?
So the capsular ligaments are right here, and those encompass and enclose the facet joint. And really that's the main stabilizer in your neck, really all throughout your spine, and where a lot of the motion comes from. A lot of neck flexion, extension, and rotation, a lot of the motion comes there. Those are actually ligaments in the upper cervical spine that are injured with cases like whiplash and upper cervical injuries. And so if you think about it, if these are the main stabilizers in your neck, and all of a sudden those ligaments are stretched out, the joint is unstable, you're probably going to have quite a few problems. Not being able to hold your neck in a stable position is going to come with its own myriad of symptoms, like especially with headaches.
One of the things that was a great explanation. One of the things when I see a new patient, I like to ask the patient, why now? Like, why did you come in now? And often what they'll describe is they'd had symptoms for a while and now they're terrible. And I think the easiest explanation of that is the body's going to do all these compensatory mechanisms to try to limit the damage because cervical instability is a progressive disorder. So obviously the first thing the body's going to do is swell the joint to stabilize it, tighten the muscles to stabilize it. But if the forces don't go away, and the forces aren't going away because people have to work 8 hours a day, and most people are looking down at papers, they're looking down at their cell phone, looking down, and it's hours and hours and hours. So because the forces continue, at some point even the muscles fatigue, and then once the body can't limit the motion anymore, that's where you start getting where spinal cord tension, CSF block, like it can go from a tension type headache to where now you got nausea all the time because your brain pressure is so crazy.
That's a very common thing that patients say is, and even when we just, did a lumbar video, like patients that throw their back out or they get, headaches or nerve symptoms in their neck, they'll say, yeah, it's happening every once in a while. Maybe, I got headaches twice a year and then they were 4 times a year and now all of a sudden I'm getting headaches every month and every week. It oftentimes progresses like that, especially with things like bad posture. If you're looking down at your cell phone, it's not a huge force on your neck, but you do that 8 hours a day plus your computer work plus whatever else, over time you still get that creep, that time elongation of ligaments. And so if you start out, just getting a few symptoms here and there, but you keep that force on your neck, it's just going to get worse. These things typically do not get better.
Yeah.
on their
yeah.
own.
Yeah, exactly. This just kind of shows the anatomy is extremely complicated. C1, C2, you have the C2 nerve root, you have the vertebral arteries. You can see where if you had instability here, it can encroach on the vertebral artery, and then the occipital nerve is a branch of the C2 nerve root. There's the greater occipital nerve here. So the point being is that there's just a lot of different nerves, blood vessels that run around the vertebrae, and the vertebral artery even goes inside the vertebrae. So it's no wonder that cervical instability could cause the myriad of symptoms.
Well, especially here, if you look here, so this is C1, this is the posterior part of C1. Like here are your vertebral arteries. There's the left one, there's the right one. If this bone is rotated or, you know, subluxed or too far forward, I mean, it's taken those arteries with it.
Yeah, and then, you know, at the Hauser Neck Center, we order blood flow studies. That's part of our routine. And then when the atlas is subluxed forward, you kink both of those arteries, and what we see on our ultrasound Doppler exams is that the velocities go up in both of them. So that's one of the things. And of course, if the vertebral arteries are kinked, then often a person is prone to dizziness and or vertigo. So that's one of the common things we see. We had this video made. So this basically explains, and then of course the person's looking at their cell phone and the hours are going by.
Yep. I mean, this is everybody. Like, we're hunched over a computer. I mean, this is everyone.
And then now if we look in, what's actually happening for hours and hours is the slow stretching of the ligaments, and the slow stretching of the ligaments we call creep, right? And then it's just going to keep getting worse and worse the more hours that somebody does it. And then of course prolotherapy, and that was prolotherapy to the capsular ligaments, and of course.
So again, the capsular ligaments that encompass the facet joints.
Then the vertebrae move in the proper way, and the nerves then aren't hit by the bones. So anybody who has intermittent, like tingling, numbness down the limb, it's probably that you got a capsular ligament injury, some cervical instability, and that causes intermittent irritation of the nerves. And then this is kind of what it would look like, you know, if you had a car accident, because, you know, car accidents, and of course, you know, all the kids, your kids already are starting to, even though they're young, they just love running around, right? And they're going to, so because we do a lot of running sports, anytime you have a collision, and why would you say that probably post-concussion syndrome is probably a ligament problem?
That's interesting. So post-concussion syndrome, essentially after somebody has a concussion, there might be symptoms that don't really go away, like brain fog, could be dizziness, inability to concentrate. And in a lot of cases, you know, you repeat maybe MRIs or scans, you follow up with your specialist, and your brain is fine, which is great. You know, everything looks great there, but you're still suffering with symptoms. And when you have a concussion, you oftentimes suffer whiplash at the same time. So if you have those upper cervical ligament injuries that are disrupting your CSF flow, or they're causing a lot of muscle tightness, they're causing a lot of issues, if that does go unobserved, then those people really continue to suffer.
Yeah, and that's one of the reasons why when somebody comes here, we, as you know, we do non-invasive tests to look at intracranial hypertension. We look at whether or not your anatomy has caused compression of the jugular vein, which of course we'll talk about in a later video. And then people forget, like, if right now, we're not going to do this, but if we head-butted, like if we head-butted, our instinct is going to be we head-butt and then boom, right? Because when we hit our head, when people have a collision, you automatically twist your head really quick. So your atlas twists really quick, and sometimes the people don't realize that the actual underlying problem is atlas misalignment or upper cervical instability. And how would we in the office here diagnose upper cervical instability?
We do a couple of things. One is a digital motion x-ray. So an x-ray where you're actually looking down, looking up. We're actually seeing how your vertebrae are moving during motion. And we'll also do a cone beam CT to look at how your vertebrae are positioned when you're upright.
Versus traditional scans or when you're laying down.
Perfectly still, which may not show us what we want to see.
This is just shows the force that it takes to basically completely tear the various ligaments in the neck, and this is how much they elongate. You can completely tear a capsular ligament by just elongating it just by a few millimeters. So you could just have a little whiplash injury and think of nothing of it, but you could, especially if there's a twist with it, significantly injure one of the posterior ligament complexes, and then it's a progressive disorder, so you actually have to do something about it.
Well, and with people that, let's say someone's in a car accident, a lot of times, like let's say we're in a car together, you and I, and we're stopped and someone hits us, I might be talking to you, you know, while it's happening, or I might look, you know, maybe look to my rearview mirror to see what's happening. And when you get that force, when your neck is twisted, it actually makes you more likely to injure your capsular ligaments. It actually puts more force on them.
Yeah.
And, you know, if it fails at 4.5 millimeters, that doesn't mean, you know, if you've stretched it 2 millimeters, you're asymptomatic. You don't have to stretch it that far to actually have symptoms. You only need to stretch it a short amount to get that instability and get a whole myriad of symptoms.
Yeah, exactly. And I was thinking in the last couple of weeks, I've had a patient who went to the beautician, you know, they went to their hairstylist, and they just were washing their hair, you know, and just because you're over the sink and then you're extended, so that was put them over the edge. Then I had another patient who had one of their wisdom teeth out. They were thinking like that was going to help them because they had, you know, headache and facial pain and all kinds of things, and it just made it way, way worse. So likely it probably was the position. So, because if you think about it, like when you're over a sink and your hair washed, that's an unusual position. Just like how often in life do you, are you in a dental chair? And then this is, I like to show this. This is Simone Biles. This is right before she was gonna do her balance beam routine, and we know that during the Olympics she had the twisties. So, and I just kind of show this that she's self-manipulating, like she was self-manipulating. So why would you say it's not a good idea for her or anybody to be self-manipulating? And what is a person who needs to self-manipulate, what does that mean?
Usually in general, we don't recommend that people self-manipulate, because when you do that, you're actually putting increased force on your ligaments as you're trying to put yourself into alignment, and you can't oftentimes control or know how much force you're using to be able to do that. And so people that self-manipulate multiple times a day, they're really stretching out their ligaments more and more every day. So if you are somebody that needs to do that, the question would be why? Why do you constantly feel that you need to adjust yourself? Why are your vertebrae slipping out of place? Is it instability? Like, do you have loose ligaments and you're just further, creating more and more problems for yourself by doing that?
The other thing her case emphasizes is that she has elite muscular physiology. So she likely has probably significant cervical instability, but because her musculature is so well developed that it does protect her. But it doesn't mean that she doesn't have ligament laxity. This just kind of shows people with Ehlers-Danlos syndrome. So the number one thing we see with a lot of our patients is that they're loose jointed. So one of the consequences of loose jointedness is all these kind of things, and included in here, of course, is cervical instability. Somebody who's able to take their thumb in here and they can hyperextend their joints, and they have multiple joints that click and pop, and you have head pressure or headache pain, it's probably has a ligament origin.
And just to kind of add to that, because I'll get patients that are obviously concerned about their joints clicking and popping, and it doesn't mean that you never have a joint that clicks or pops. You could move really quick and your shoulder might pop, and it doesn't ever do that again for 6 months. There's a realm of normal there, but when it's clicking and popping all the time, it's associated with symptoms, you feel like you have to click and pop your joints a lot, that's when we're concerned for instability.
Yep. And then this is, like you had mentioned, the digital motion x-ray, so why don't you explain this?
Yeah, so if we start with this first one up here, what we're looking at, I'm just going to get down. So this is C2, so that's your second vertebrae in your neck, and then these kind of squares right there are the ring of C1 that sits on top of it. And what we look at is to see if they are in alignment when you are in neutral and then when you lean to the side. So here you can see that C1 is sitting on top of C2 nicely there. And what we would also do is when you lean to the side, see if your C1 like slides off. We can also see if your C2 is rotated or if it's in normal position by looking at the spinous process. So this back part, you can actually feel it if you kind of put your fingers to the back of your neck, because that should be in line with the dens. And you can see here, like this is a spinous process that's rotated to this, that's off of the midline. So that tells us that your C2 is actually rotated. Moving down. Horrific curve, yeah. So a normal neck curve should look really kind of like a C, like it's lordotic. And this one is like straight and curving forward, like curving in the opposite direction and just kind of tilted in general. So really this person's curve is definitely way off. They have like very significant forward head posture. And what happens, if you have forward head posture, is basically your head's a bowling ball, right? So if you're holding a bowling ball like really close to your body versus you hold it way out here, it's gonna put, holding a bowling ball way out here is gonna put so much more strain on your ligaments, on your tendons, on all your soft tissue. So that's what's happening in the neck here.
So you mentioned a bowling ball.
So obviously you have one. Yeah.
No, but I'm saying though, like the head weighs 10 to 12 pounds, so this weighs 10 to 12 pounds.
Okay.
And isn't it always when you hold a 10 to 12 pound, it's like enormously heavy?
Yes, it is actually very enormously heavy.
And then think about this 10 to 12 pound thing on a 2-ounce atlas.
Yeah.
So you can't over time just have that forward, forward, forward. So one of the reasons that you have to have the bowling ball on top of a good curve is then the force of the bowling ball is going to go behind the curve. If the bowling ball is way out here, it's going to propagate or it's going to accelerate the cervical instability process.
So if you think like this bowling ball here, like it's still heavy and I'm holding it close to my body, but if I were going to hold it like out here, over time, my wrist, my elbow, my shoulder, like they're all going to get affected because I'm holding too much weight in an improper position for too long. You should be able to draw a line like along the back of the vertebrae, but you see how this looks like a staircase? And then we have the specific measurements here. Like this is not normal. This person has instability at every single level here. And this is with looking down, which is our most common position that people are in day out. So if you think about it, like if they have all of this instability and then they spend 8 hours, 12 hours, however long every day looking down, exacerbating that, they're not going to feel good. It's not going to be a good thing long term.
And then when the ligament is stretched too much, it will stretch the nerve endings in the ligament, and that sends a reflex arc to the musculature. So then that's why the muscles tense.
Yeah.
So anybody who has chronic muscle tension, it's likely that you have ligament injury in the neck. And then this is a great 3D rendering. So where are the prolotherapy injections given?
So as you can see here, they're given to the capsular ligaments in the upper cervical spine in this diagram. So here, those are the ligaments injured, and then of course prolotherapy to restore stability. And usually, a lot of our cases are like that at last x-ray we saw where they have instability through multiple levels. So we would do prolotherapy to multiple levels at those capsular ligaments.
And then traditionally prolotherapy is given every 4 to 6 weeks. We do have some cases that are very severe, like somebody who has extreme dizziness, heart palpitations, terrible vertigo. Of course we might fast track it, see the person every couple weeks. And of course there are times that the instability is so severe that it's actually extreme that we actually have to have them wear a cervical collar. But while they're doing that, we do have them do what's called curve correction, which is, you know, getting your computer screen up, and therapeutic exercise, and of course wear certain kind of weights to help them get back the cervical curve.
Well, if you do, you know, a really good job of doing prolotherapy and tighten these ligaments, but the patient's curve is still horrific, you know, they still have like terrible forward head posture and like a straight curve, you know, we don't want symptoms to come back if we can help it. So if we can get that curve to be in a more lordotic position, then it's just better long-term for the patient.
Yep, and then this is just some of the results from years past. So prolotherapy, doctors have been doing prolotherapy for headaches for the last 60 years. Dr. K-Fitz and his group, they had a 75% cure rate. And then of course Dr. Hackett, who originated the term prolotherapy, of course he had good to excellent pain relief with headaches in over 90% of the patients. And I would say that headaches is one of the symptoms that really responds very well to prolotherapy.
Yeah.
So thank you everybody for watching, and thank you for being here.
Thank you.